So we've been called to a 70-year-old male who has collapsed and is complaining of chest pain. It was an acute onset where he began to feel dizzy and was unable to remain standing. The patient has a past medical history of cardiovascular compromise where he had an MI 5 years ago. However, he has described the pain as being quite different. He is on cilazepam and aspirin, which, as we know, are both cardiovascular medications. On presentation, the patient appears pale and clammy. He describes the pain radiating into his neck and feels like his heart's going to jump out of his chest. He does have a decreased GCS made up of 3, 4 and 5 to give a total of 12. His vitals that we've taken: heart rate 170, blood pressure 70/40, rest rate of 18, BSL of 7.6 and a temperature of 37. We have had a look at the 12 lead, which after analysing quite carefully has shown that he is in VT. It is important to note that we need to be careful of other differential diagnoses such as SVT with aberrancy or other causes such as electrolytes. So we have worked through some rules there to determine that this patient is in conscious VT. Based on these findings, we now know that the patient is hypertensive. Having had a listen to their lungs and hearing some fluid in the chest there, suspicious of pulmonary edema. He obviously is complaining of chest pain and has a decreased GCS. We therefore know that this patient is significantly cardiovascularly compromised, and I would give him a status 1. Therefore, it is important that we therefore call for a backup. So I would, on my radio, call for an R50 asking for an ICP, and thinking here that we will need to start looking at electrical cardioversion. Given this patient's past medical history and his current presentation, we are quite suspicious that this is cardiac related. However, it is important that we don't rule out other causes such as infection. That's why it's important to obtain a full set of vitals so that things like the BSL and the temperature, which are both normal in this patient, can rule towards cardiac related. Thinking about VT versus SVT with aberrancy, it's important that we do go through our processes and work through some rules, which I've put up on the screen now, to make sure that we have accurately diagnosed this. Now that we have a diagnosis for this patient and we have called for an R50, we can begin the cardioversion process. So as you can see, the patient is supine and it is important to get them in this position first. I have previously gained IV access for this patient in preparation if anything is required to be administered. It's worth noting that the patient must be adequately sedated for cardioversion. As this patient is unable to obey commands, that is not required in this situation. However, if it was, we would be looking at administering ketamine, having called the clinical desk first. The pads have been attached in the apex and sternum position, so now we are ready to start working through our process. It's worth noting that I do have my resus equipment on hand here, should anything go sideways. So now we're ready to start the cardioversion process. So we have a checklist here in our CPGs that is essential we work through point by point. I would be communicating this with my offsider as we go to ensure this is done accurately and everything is done. So first on the list, ensuring that the pads are in the apex sternum position as recommended, which they are. We then need to make sure that the defib is in manual mode, which I have set, but I'll double check that. Next of all, it's about selecting a lead with the highest visible R wave and the least amount of artifact, which I have done here, and I'm happy with that. We then are placing the monitor in synchronizing mode by pressing the sync button here. Now, it's important to ensure this is synchronized to make sure that there is a detection symbol above each QRS complex, which we will do by printing a strip and having a look. So having a look here, I can clearly see that there is a detection symbol above each of the R-wave complexes there, which accurately means the defib is synchronized with the patient. Next on the list is ensuring that the patient is adequately sedated. As discussed, this patient is unable to obey commands. I will, however, double check this. Patient, sir, can you hear me? Can you hear me? I'll just get you to poke your tongue out for me. Open your eyes, mate. Patient is unable to obey commands, therefore sedation is not required. Next on the list is selecting the joules, so we will do that at maximum joules here, which I've previously set here. Now the next part is delivering the shock, which will cardiovert the patient hopefully back into a normal rhythm. As any other shocking situation, we need to ensure that everyone is clear here. Okay. So first of all, I will charge the defibrillator. Press the charge button. It is now ready to shock. So first of all, everybody clear. Make sure no one is around, and I'll press and hold the shock button. Clear. Having administered the shock, it is now important to reassess the patient. So as you can see on the monitor here, the patient has reverted to sinus tachycardia, which is a desired outcome. Unfortunately, this is not always the case. So if the patient remained in VT and we're considering a second cardioversion attempt, it's important that, again, we work our way systematically through the checklist in the CPGs, ensuring, again, that the patient is adequately sedated, that the monitor is in synchronized mode, and that we confirm that by looking at those detection symbols on top of the R-wave complexes. However, as this patient has reverted, it's now important that we go back to assessing the ABCs, vitals, and the GCS. So in this case here, we can see that the patient's starting to communicate and respond. His GCS is improving, but we've got all of our resus gear here, including oxygen, to help that if need be. This next simulation will be for the RSI assistant preparation. So we've been dispatched to a 40-year-old male who's fallen 6 metres off his roof onto the concrete driveway. This was witnessed by the neighbour. There's no known past medical history for this patient. On presentation, we've discovered that the patient has an isolated injury to the back of the head in the occiput region with an obvious boggy patch of roughly about 6 centimetres. The patient is posturing and seems to be extending. He's quite restless and combative. In terms of his breathing and his speech, he's moaning quite a lot. He seems to be holding his breath, and he is groaning. Therefore, we've given him a GCS of 6, made up of 2, 2, and 2. The vitals read heart rate 50, blood pressure 160 over 90, respiratory rate of 12, BSL of 7.6, and a temperature of 37. Given the significant decrease in GCS, along with the mechanism of injury and that boggy patch, we're fairly confident this patient has sustained a significant traumatic brain injury with a quite high risk of compromised airway. Therefore, I have called in an R50 for a RSI, and they've come back to me saying that that is 10 minutes away, and if I could please go ahead and start the RSI preparation progress. So, just like the cardioversion, it is essential that we are working through the checklist that is provided in the CPGs, going through each point, and again, I would be relaying that with my offsider to ensure that we've done this accurately and everything is set up ready for that ICP for when he arrives. So, getting cracking on that. So first of all, attaching nasal prongs without oxygen, which we have done, and they are not attached to oxygen. Pre-oxygenate using a reservoir mask at 10 litres per minute. So we have the mask here. Ensuring that that is at 10 litres per minute. Next on the list is attaching all of the monitoring equipment, such as the ECG, blood pressure, and SpO2, which we have already set up here, and all attached for the patient. Capnography is on hand too for the RSI to measure that in terms of the breathing there. Next on the list is positioning the monitor so that it can be seen and leaving enough space to the right of the head here for that for the RSI to take place. So we have the monitor here for everyone to see and the space. Next on the list would be gaining IV access, which I've done. I've done that in 2 sites on both arms there. I have also prepared a running line here of 0.9% sodium chloride into the patient. What I have done also next on the list to maintain optimum airway control is I have positioned the patient in a sniffing position, ensuring that the airline there is in line with the sternum to ensure that that airway is nice and parallel. Placing an ET tube holder on the underneath the patient, getting ready again, is next on the list, so we will do that. Next on the list is testing the suction, which I have to my right here. So turning that on, ensuring that it is working, and then also the suction. Cool, so I'm happy with that. Turn that back off and placing that under the patient's neck and ready to be used on the right-hand side here. Cool, so next on the list is ensuring that we've got a manual ventilation bag mask ready here, which I do. I've also attached the PEEP to that. Now it's worth noting that PEEP for a traumatic brain injury is less at 5 centimetres of water pressure as opposed to the 10. This is to do with the intrathoracic pressure and ensuring that we're not compromising the patient there. So that's all set up, ready to go. Next of all would be obtaining another full set of vitals. For that, we can relay back to the oncoming ICP so that he is aware of the most up-to-date condition of this patient. So having done that, I would then call the clinical desk and ask to be put through to the ICP, ensuring that I update him on the GCS score as well. Heading down towards the last section of this preparation list would be ensuring that the environment is nice and clear. Obviously, space for the ICP to come in, but also having enough space to move around and do the work and treatment as needed. So having done that, I'm happy that the preparation is now complete, and obviously confirming that with that off-sider again. Now, alongside the RSI preparation, it's important that we do not actually forget this underlying condition of the patient, which is a major TBI. Therefore, it is essential we treat as such. Firstly, obviously with oxygenation to combat that hypoxia, and also make sure we're monitoring the blood pressure in case we need to combat hypertension, thinking about fluid resuscitation. It's also worth thinking about morphine, administering that to the patient. That can really help with that combativeness that we're seeing. Now, unfortunately, not all intubations are successful, and it's worth considering if this were to happen, what our other options are. So obviously, we have other adjuncts that we can use, such as a bogey ETT, which can help place that airway. Also not neglecting other things, such as the OPA, NPA, and the LMA, which I have got pre-prepared here ready in case we do need to use them. The Vortex approach is quite a nice look at airway management, where we can have several attempts at each of these adjuncts, ensuring that we're looking at the right size and things such as that. However, if these are continuing to fail and we cannot maintain an adequate airway with these adjuncts, we would then need to think about a crike as being that next option.